For this chapter, we'll be talking about ADHD mimicking conditions. These are conditions which can be confused with ADHD. The first one, which is very interesting, which comes up several times per year in my office, are seizures. The story will often go like this. A teacher will say, "Your child's symptoms have been really acting up lately. Their ADHD has been exceptionally bad. I often catch them staring off into space, not responding when I ask them questions, calling their name repeatedly until finally they respond. To me, this always raises a little bit of a red flag and wondering if these staring spells are not something behavioral, just daydreaming that goes along with ADHD, but might be something like a staring spell seizure." The first thing I do is ask the family to characterize the spells a bit better. So there's two things that you can look for that'll help differentiate between a staring spell seizure and just a behavioral episode of daydreaming. One is if there's any behavior arrest or suddenly stopping activity. This means a child will be talking, maybe even mid-sentence, and stop. The activity that they're doing could be talking, could be some sort of other sport, even walking will suddenly stop and stare. That behavior arrest or stopping activity is strongly suspicious for a seizure and less common in children who have behavioral staring spells. A second sort of feature you can look for in determining if a spell is a seizure or just a behavioral episode is arousability. This means, can a child be stimulated out of the spell? Calling the name often doesn't count, especially with teenagers. You look for things like a shake on the shoulder, a touch on the cheek, tickle under the nose, or even kind of an old-style neurology method of a very loud clap in the child's face, which I always think is a little bit extreme, especially if they are just behavioral spells. But from a staring spell seizure, you shouldn't be able to be aroused out of the spell. Or for a behavioral spell like daydreaming that might go along with ADHD, you can be aroused out of it. So this is where families will say, well, I do see them staring off a lot, looking out the car window when we're driving, or just staring off like they're zoning out when they're watching TV. Those are spells that are not very well characterized. So the two features we look for, having any sort of behavior arrest, which is suddenly stopping activity, and then decreased arousability. There's some medical disorders that can affect brain functioning and look like ADHD. It's going to be very serious conditions such as leukodystrophies, other sorts of tumors or vascular malformations which may have some ADHD-like behaviors associated with them, especially early on, to more benign things such as blood sugar irregularities or even thyroid dysfunction. These are often things that I consider, rarely test for, but have in the back of my mind when I'm making an ADHD diagnosis. Learning disabilities can also mimic ADHD for a couple reasons. One is that, remember, there's a difference between preferred and non-preferred activities. So a non-preferred activity, something the child finds boring or hard, they may be less attentive to. If you have a learning disability, say dyscalculia or a visual or auditory processing disorder, you're used to failing at your homework and struggling with it, it becomes a non-preferred activity, so there's inattention and distractibility there. But then other things, if you have a learning disability, it may be taking you much longer to do your homework or complete your tests at school because you just don't understand it. This is important for consideration of psychoeducational testing that helps sort through, is there a primary learning disability or is this just a behavioral disorder, ADHD? Another mimicker, which at times can be confusing, is comorbid depression or even primary depression, which looks like ADHD. Where I run into this most often is in adolescents who come into the office, they have a flat, depressed affect, depressed mood, may talk about things like sleep irregularities, not taking pleasure in things they used to like, eating too much or eating too little, but they're coming in to see me for possible ADHD. This is where history is important. With these kids, I'll often go back and talk to the families about how are they doing in early elementary school. If they go, oh, they had terrible attention and distractibility problems or hyperactivity and impulsivity, that'll make me think, I think the primary diagnosis is more ADHD, and maybe even after years of struggling and failure have developed a little bit of a mood disorder. But if I don't get much of an ADHD history from early childhood, early elementary school years, and are now just starting to get symptoms of depression with inattention distractibility, it might get me more leaning towards figuring out a diagnosis and treatment directed towards depression. So ADHD, comorbidities, and mimickers, very important to consider before making a diagnosis of ADHD.